possibility, there's grant money that we have additional people coming in to do some tutoring, but it's not available until October. So, we are going to try for this Thursday to get you a room. However, the practical application, meaning the moving that you'll be doing of each other, can't be done because you won't be supervised. If you'd like a room with which to be able to communicate and study, that can probably be done. So just let me know. I have to call her again when we're done. So just let me know if that's something you want. Again, if you want to practice, I may be able to get Professor Maley to stay for an hour, and I'll ask him to come in, and maybe we could get you to practice in the lab. But again, let me just confirm that with all of you. I'll confirm it with you tomorrow via email, okay? Can you turn that on, please? All right. So we talked about psychological trial, we talked about joint movements, we talked about I don't think we talked about any common definitions, but we talked about sagittal plane movements, we talked about 3 degrees of freedom as opposed to 1, as opposed to 2. We talked about the names of some of the joints. For Thursday and tomorrow, I'm going to tell Professor D'Onofrio, you will still be doing transfers, because do you need a lot more time on transfers, do you think?
Yes. Oh, yes.
Okay. So we'll still be doing transfers. I wanted to start passive range of motion, but it's up to you guys. If you think you need a whole full day of transfers, that's fine. And then we'll start passive range of motion next week.
Cool.
What do you want to do? Do you want to do that?
That sounds good.
Yeah.
Okay, because with passive range of motion, well, just so that I don't forget to say it, there is a chapter in your patient care book of range of motion, active assisted, passive range of motion, and it has a PNF portion in it. I'm far enough away from you. Is that okay? There's a PNF portion in it, because it's easier for me to talk. And can you hear
Yeah.
better?
Yeah.
Okay, there's a PNF portion in that. Do not do the PNF, okay? PNF is for next year. So just do the passive range of motion. Pay attention to the joints, because it'll tell you, as I asked one of the kids in the class today, flexion and extension, a condyloid joint involves how many degrees of freedom? 2. And they are, let's name one. And you guys named this morning for me the radiocarpal joint. And what's the movements that occur at the radiocarpal joint? Flexion, extension, ulnar and radial deviation. Or flexion, extension, abduction. Okay? Same thing with the thumb. If I said degrees of freedom dawn with the glenohumeral joint, how many would you tell me? Radio, humeral, what did I say? Glenohumeral. Did I say glenohumeral?
Yeah.
Range of motion of glenohumeral joint, Dawn. How many degrees of freedom does it have? 3. And what are they?
Flexion, extension, abduction, adduction.
Okay, can you demo that? Can you stand up and demo that? Yes, you can. Stand up. Yes, you can. Stand up. Show me flexion, extension, abduction, and internal and external rotation.
I don't know which one it is.
Of the glenohumeral joint.
Shoulder.
Shoulder.
Got it.
Go ahead. What is that? Flexion and extension and
Abduction, adduction.
abduction all the way up. Adduction all the way up. Internal and external. Yeah. Either this or this. Right? Yeah, you know it. Don't be so afraid. See, now, if we were in the other class, I'd pick on you all the time, all of you. Well, I could still pick on you. I'm getting to know your names, so I gotta pick on all, I gotta pick on all of you.
It's fun when she gets you.
I'm a universal picker. All right. Okay, so we said that the, blah, blah, blah.
I think the last one we got was
Yeah.
joint structure.
No, we talked about we talked about spiral fractures last time, right?
Oh, you're right.
We talked about spiral fracture, we said that was one that we have to worry about if somebody has, or suspected a problem with child abuse, right? Because the spiral fracture is a twisting or a torsional injury. We said an impacted fracture is one where the bones are impacted or the bones join one another, such as if you jumped out of a window. Or another impacted fracture, I had a friend who was very, very thin, and we were at a ski resort area, and she came down the hill on one of those pads, and she was very, very, very slight, and she hit a bump of ice and came up, and there was a tree, trunk, and she had an impacted sacral fracture. Because you could imagine, her little body flew up, she was a tiny little thing, and, we laughed, and then she couldn't get up, and we, and we went, I didn't laugh purpose, we thought nothing was wrong with her, but then later on, we found out she had an impacted fracture. But we were young, huh? Okay, so different types of disorders that there are, there's a lot. Right now, we're just gonna mention two. This osteoporosis is when I said it can lead to a pathological fracture. And what did I say a pathological fracture was?
Like a health condition, like a fracture
One
caused by a
associated
health
with the
condition.
disease, right? It's pathological. So a pathological fracture doesn't just happen, it's a result of its disease process. So I said if somebody had cancer and they had metastasis, what's metastasis mean? It spreads. So if you have metastatic cancer, carcinoma, and you've had it maybe in your breast, and now it has spread to the spine, it's something we would certainly have to be aware of. If this person has metastases, even if they don't know if they have metastases, and they come in and they start talking about pain in some other area. And I gave you the example of the woman that I worked with went to a country club. She was coming in for a knee problem, and she said, oh, but my thoracic spine is really killing me today. And I asked her what she did, and she said, nothing. I hung out with the girls. I went to the club. We had lunch. We had wine. I said, what did you do at the club? Played golf. So she had a thoracic fracture secondary to the stress that she put on the spine when she swung the golf club. So it's pathological or resulting from a disease process, okay? As opposed to osteomyelitis, and osteomyelitis is a bacterial infection of the bone. Very, very painful. Someone suspects that they have osteomyelitis, they have to be on IV antibiotics. IV antibiotics, okay? So they get this person in right away, put them on IV. Want to save the bone. Yes?
You know, most of these are compound fractures, correct?
Compound fracture is one where, yes, where the bone is out, comes out through the skin, and it can become infected. But there are other things that, you can get an infection from a fracture. You can get an infection during the time that they're doing the surgery. Infections can happen anytime. So, yes, but if you have a compound or an open fracture like that, you're much more susceptible to getting something because you want to make sure that the area is clean. Okay, so osteomyelitis, they put that person on an IV antibiotic. I did find a patient one time that had osteomyelitis. He had an open reduction internal fixation. So open reduction is they have to open you up and they have to fixate you. And he came from Africa, and he was coming to visit his parents. And when I was examining him and working with him, I noticed that he had a great deal of edema and redness, and he had an inflammatory process going on. And when I went to palpate the hip, I went up to the thigh area and the inguinal area where there's lymphatic system, and there was a lot of edema there. And so then his wound was oozing, and I cultured it, and he had osteomyelitis. So they stuck him into the hospital immediately. They put him on antibiotics, IV antibiotics, and we saved his leg. But this can happen, so keep your eyes open. All right. Fracture reduction, for now, we're not going to talk so much about fracture reductions, but we'll say that there are closed and open reductions. A closed reduction is when they don't take you into surgery. They may just align it while you're in the emergency room or when you're in the office, and then they take an x-ray to see the alignment is properly done, and then they cast you. Okay? Open reduction will require some kind of surgical intervention. And whether they fixate it internally or externally depends on what needs to be done. Okay? They always talk about orthopedic surgeons being kind of like car mechanics. You have wires, you have screws, you have rods, you have nails. Sometimes they do an internal fixation where they put a rod or they put nails or they put a plate and then they screw it together. And over time, it's not uncommon to see if somebody's ankle, maybe the nail or the pin starts to migrate to the surface and get in the way of a patient's range of motion. Or it just causes the patient pain. So you start to palpate it, notify the surgeon, say, this wire or this mesh, this wire, this nail is migrating, this screw. And they go, all right, fine, bring the patient in, we'll take it out. Okay? As opposed to an external fixator. An external fixator, they kind of look, it's scary when you work with these patients that have X-fixes because there's usually pins, and sometimes they call them Steinman pins, and they name them by the manufacturer, and the pins are stuck through the bone.
Would it be like a halo?
A halo is an example of that. And they put it in the cortex, and then they put the rim, the halo, guys know what a halo is? They drill 2 holes here into the cranium, and then they put a round circular metal object that's kind of like it's known as a halo because it looks like an angel, and then they do uprights, and they attach it to a vest. And the reason they do that is to prevent you from moving your head. So you have an unstable fracture, and they want to secure it, but they don't want to keep you in bed. So maybe you have an incomplete fracture, they do a halo, they want to, or any kind of cervical instability, and they keep you in that position. What happens when you have your head like that, and it's just going off the tangent a little bit, but it takes away the normal curvature of the spine. So these patients, when they're standing up, they feel like they're falling forward. So it's something to note when you first get these patients up. Okay? But an X-fix is something you guys, I'm sure many of you have seen this. There's pins in the tibia or the femur, and then they have this cage wrapped around it, this big cage of metal. That's an external fixator. And it looks scary, but the pins are doing all the work. The cage is just making sure nothing moves. Okay? So they do an intramedullary rod, that's an internal fixator, or they do an X-fix. Okay, the X-fix comes out. In the case of a halo, or in the case of a Steinman pin or anything, they take a hand drill and they drill it out. So you come into a orthopedic setting, and then take the drill in, or they take a power drill, and then pull it out, and it bleeds, and then they just wipe it off, and it's fine. Because it's certainly not through the head. It's just in the cortex of the bone. Okay. So an external fixator is temporary, and an internal fixator stays there until there's a need to take it out. Okay? Some people have pins and plates in forever. Any of you have plates or pins or rods? Yeah. From knee or
It's
wrist?
in the tibia. It's from my
Tibia?
wrist. Yeah. I mean, my leg.
Okay, so here's some common definitions that we'll talk about. Common definitions, power, and power meaning it's work over time. Okay? When we think about work, though, what is work? Work is force times distance. So power is actually force times distance over time. Strength is the ability of a muscle group to produce tension. So it can either be done, you can do this dynamically, you could do this volitionally, you could do this statically. Volitionally means you're doing it on your own. You could take an external stimulator or a electric stim machine, and you could zap somebody's leg to try to make the muscle contract. Okay, that does not produce strength because that is something that's passively done to a patient, but it's a static or dynamic effort that's placed on the patient. Endurance, now we have whole body and we have muscular endurance. So if we're looking at somebody's function, we may need to look at their endurance because it's their ability to perform these motor tasks in their activities of daily living. So think about total body endurance, which is going to require low intensity exercise over a long time doing it. Okay, so maybe you put somebody on a bike for a half hour. Or maybe you get them to do sit to stand, 10 sit to stand exercises. So these are more functional exercises as opposed to just strengthening for a muscle endurance for a limb, like doing a knee extension on an open kinematic chain machine. What's the difference between open and closed? Oh, did we talk about that? No, okay. Yeah. But if I sat here and you put me on a knee extension machine and I was doing this is not really very functional, right? I mean, does it help with strength? Yeah. But would I benefit more functionally and working on total body endurance from getting from a chair and standing up? So I would do a sit to stand activity rather than kicking the machine. You know, these machines look very, very impressive. Patients always like them, but are they necessary? You know, I sometimes think you could get more exercise going to a park, and even if you were going to do push-ups or something like that, just go over to the park bench and do this, you know, rather than getting on the floor. And you know, there's monkey bars and all this kind of stuff. There's so much more that you could do getting up and sitting down from a park bench. It's much more functional. Don't tell your patients that. No, I'm just kidding. Tell your patients that. You know, that's something they should be doing while they're home. Just getting up from a chair. All right, flexibility and mobility. Flexibility and mobility are necessary. We need to be flexible and we need to be mobile. Okay, we also need stability. Remember all the time I talk about the fact that we need a stable trunk off of which to operate with mobile arms and legs. So we need the stability here to have mobility here. Anytime you have a really, really super athlete, he's very strong here if this has to fly in the wind. You know, because you need the mobility, you need the stability to get the mobility. Otherwise, your center of gravity is off, you're not within your base of support, and you're not very good. So we need to be stable and mobile. Can you think of somebody who has less stability initially? Anybody who's performing a novel task, right? We talk about tasks, we talk about new activities. If somebody's just going to learn how to play baseball or learn how to play soccer, they're not going to have the stability one might have with experience. Think of a child. Anyone have children in here? A lot of people have children here, right? You think of when they start walking and they have to hold on to something and they do something called cruising. So they hold on to, where's Cindy? Cindy, your kid doing that yet? No, she's 10 months of cruising? Yeah. So holding on to something while they're walking, right? So the stability is coming, and that's also the coordination. I always say every front has a back, so we have to have coordination. If the anterior side is not as strong as the posterior side, then there's going to be a problem somewhere. There's going to be a kinematic breakdown, right? And I also said to you the other day that somebody say, oh, I do exercise. I exercise in the gym all the time. I do my back all the time. I don't know why. My back is really strong. Because you say to somebody, well, we really have to work on those scapular muscles and all. And they say, I do my back. And what do they say when they do their back? They're only referring to the latissimus. And latissimus also works the shoulder in an anterior direction. So it's not a good thing to do. All right? You wouldn't put somebody who came in with a rotator cuff tear on a lat machine. Yet you see it done all the time. Okay. Relaxation. It's our conscious effort to relieve tension in our muscles. We need relaxation. Why do we need relaxation? Because if you don't use something known as biofeedback, and it's kind of a lost art, a lot of people don't use biofeedback in their clinical settings anymore. Adi, you do massage therapy, right? Do you do any biofeedback? No? Because, I mean, you massage people's necks, right? You don't? What do you massage? I didn't hear. Oh, you're an aide, but you're not, aren't you a massage therapist?
No, I took classes for it, but not licensed.
Oh, okay. But when your patients come in with cervical problems, you see sometimes, if your therapists are good, they like to do manual work, right? So they may do some craniosacral, they may do some suboccipital work, they may do some traction, cervical traction manually, some occipital release, some stuff like that. But if you do all that, and the patient is like this, what's going to happen when the patient leaves your facility? They're going to be like this. But then they're going to come in 2 days later because they're like this. Number one, you as the therapist have to be a detective and say, what is it that you're doing that's causing you to be like this, right? So you have to ask them questions like, what kind of, ergonomically, how do you sit? What kind of job do you have? What do you do all day? How many people are housewives? And you see it, so don't tell me you don't. And house husbands, I don't mean women, men also. In the ShopRite, I mean, you all go to a ShopRite or a Food Town or something, right? And they're pushing the cart, and they got a phone, because you can't live without that illuminated box, right? You all have an illuminated box. And I see some of you use that illuminated box. See, I don't like it. More than others. How do you hold that how do you hold the phone? When you're pushing a cart and you're reaching for it, you're like this, right? So that woman is shopping, or that man is shopping for an hour. And she comes in and see you the next day, oh, my neck is killing me, or my disc hurts, or whatever. This is all ridiculous. So you have to tell a patient all this stuff. That's the part of the education you need to do. Show me how you hold your phone. Show me how you wash your dishes. Show me how you put your clothes in the dryer. Show me how you do this. Show me how you lift your child. That person that's got an asymmetrical pelvis or an anterior-posterior innominate. What is an innominate? It's the pelvis, half of a pelvis is an innominate. So one ilium, one sciatic, ilium, ischium, and pubis. It's on half the side. It's on both. So it's an innominate. They stand and they hold their kid like this, or they hold their kid like this, or they hold their purse like this, or they carry their backpack like that. You know, so all these things have to be paid attention to, because we develop improper and incorrect motor patterns, and then they need to be changed. Okay? I showed you guys the first week of class that somebody might have tight hamstring muscles. And if you don't work into that new range after you have stretched their hamstring, they will come back with the same range they had every time, which is wonderful for you if you want to see that patient forever, just to stretch their hamstrings. I mean, there's a whole lot more things that I'd like to do rather than stretch somebody's hamstrings. Okay? So you have to pay attention to the way somebody walks, the way they sit, the way they stand. You know, we're not all symmetrical. Right now, I'll share this with you. I had surgery, and before I had surgery, I had what they call a severe valgus deformity. So the valgus deformity made my leg come out like this. As it came out like this, everything was shortened on this side, lengthened on this side. I had a functional scoliosis. I had not a structural one, functional scoliosis. I had one pelvis that was higher. They kept saying to me, you have an innominate, you got a back problem, no, I didn't have any of that. What I had, and they said you had a leg length discrepancy of 1 inch. And believe me, it looked like that because when I stepped from one leg to the other, I dropped 1 inch. It was all alignment. So when I first got this leg done in June, I was not able to sit in a chair because I had excruciating pain on this side, because now my body was like this instead of like this. You know, I really am urging my therapist that I'm working with, because we kind of, like, we're doing this together. And I told her she should lecture to HSS Hospital for Special Surgery and talk about this very fact. Because a surgeon just does surgery. That's all they do. So I fixed your leg, it's okay, now go. Well, now this hurts, and this hurts, and this hurts. I don't know, I fixed your leg, it should be okay. Okay, so this is where you have to come into play and say, let me figure this out. What has been short, what has been long, what needs to be stretched, what needs to be strengthened? How are we going to tell the brain to recognize this again? Because for how many years have you been doing this incorrectly? Right? That's why I'm a firm believer of, just like you go to a dentist, but just like you go to a dentist for a checkup, you go once a year? Maybe? Twice a year? Okay, so maybe twice a year, once a year. That's where people should be coming into our offices, once a year. Does everything look okay? If not, let's fix it so that it doesn't become a problem. And I think hopefully that's where we're heading. But yeah.
As a professional in the field, have you seen a huge increase because of technology with things like upper cross syndrome and all that? A lot more occurrences of people coming in with that forward head-toe position. That really
Absolutely, absolutely. And because of our illuminated boxes, what do you think you're seeing?
More cervical herniation.
You're definitely seeing forward head. There was an article in the New York Times about our horn. Did you hear we are all developing a horn on the occipital horn syndrome? Because with the pull of the extensors are attached to the occiput and the atlas on the posterior surface. And as it becomes a tractional injury where the tendon starts ripping off, so the bone now has gotten bigger. It's gotten bigger to give it more surface area to attach to, so we're developing an occipital horn, and they found it in like kids that are 5 years old. Because what do kids do? What do you do?
You got any news?
What do you do? This is what you all do. You all do, I won't turn it on, but this is what I see it. And then, you know you all do it. I'm probably the only one that does this when I'm in a doctor's office or I'm in an office waiting for something. You know, if I have to look at my phone, I'll bring it here.
I've actually been better at that because my eyes are getting worse, so I have to do that now.
Shut up.
So it's
But I'll do this. I won't do this, but you see this all the time. You see this with 3-year-olds. You know, they'll swipe they know more about this than you do, right? I mean, Cindy, you have a 3-year-old? Do they use the phone?
No.
Oh, well, you're a good mom. But a lot of them give their phone to their kids and let them swipe, and they play games, and this is horrible. And as I said, you're only using this. There's no crossing. Get that kid out. Get them swinging the ball. Make those connections across the corpus callosum.
Has there been further research to actually back that up? Because wasn't that on the condition?
Yes, it was on, and they said, this is what we think we're seeing, but it is.
Mm-hmm.
It is definitely what they're seeing. Yes, there's been other people
So
doing
there's other
research.
studies out there on it.
Yeah, because everybody wants to say, no, that's not true, because this is a big money business. I charge you all to become billionaires. You all want to be a billionaire?
Go into tech.
Figure out a way to prevent that. I still cannot. I mean, I thought about the fact, maybe we get an app that after a certain amount of time, it shuts the phone off and won't let you use it again. But Apple doesn't want to buy that. Nobody wants to buy that, right? And people don't want that. So what do? Nobody's going to wear a brace to keep them up, so they have to look that way. I also thought of maybe intermittently putting a game on that causes you to look up instead of down. That interrupts what you're doing, but nobody would buy that either.
My wife has a sensor. When she goes into this inflection, it buzzes her.
Yeah,
Couldn't use it.
it's just, yeah, Adi. I'm sorry, I can't. What's he saying?
They have eyeglasses.
Eyeglasses.
Yeah, and the screen's there, and the screen will see your retina.
Yeah, but aren't we just doing another bad thing? You're putting everything in your glasses. Did you hear about that lady, and I forget where she was, she was in a mall and walked into the pool because she wasn't paying, because she was doing this, and she sued and she won. No, I would never have paid her, because she was doing this. But she didn't even see that, and how many people, I mean, you know, you see, and you get road rage too, you get people driving that blow horns and all because you're walking across the street and you're doing this. And when you're doing this, aren't you even walking slower sometime? Or you're even playing a game? But doesn't that hurt you? Maybe it doesn't hurt you now, but it will.
Sometimes I see people driving crazy, and I look over, and they're like driving like this.
Oh, yeah.
You know.
You should not text and drive. Who texts and drives? You can be honest. You text while you drive? See, I appreciate your honesty, but it's not a good thing for you or for the other person.
Not even at a red light.
You know? I mean, it's just, okay, so that's my soapbox on service fund. All right. So flexibility and mobility. Oh, we did this, right? Oh, it's a repeat. Oh, local muscle fatigue. Okay. When you fatigue a muscle, or when you go to fatigue a muscle, the muscle stops reacting, so it's a diminished response to some kind of a stimulus. Now, that stimulus can be mechanical, it can be manual. So if I think about a manual stimulus, if I want to increase my extensors, I could tap somebody, and tapping is a good way to get them to facilitate extension. So I could use tapping as a technique with neurologically involved patients. I could also place an electric stimulation, 2 pads on, to get stimulus. There's a difference in both things, and there's a big difference in volitional movement as well as electrical movement. So if I'm going to use an electrical stimulation on somebody, I'm going to stimulate all or none. So I'm going to recruit all of the muscle fibers and not use them as they need to be used. We'll talk about that when we talk about electric stimulation. All right, recovery from fatigue. It's the time for a body to come to the pre-existing condition. So when you overwork a muscle, it could either be a temporary problem or a permanent problem. So we get a deterioration of strength over time, over the amount of time we work the muscle. And this can result in something that's transient. Transient means it comes and it goes, it'll go away, as opposed to something that's permanent. So if we're overtaxing a muscle, and what is a muscle attached to? A muscle attaches to a bone via a tendon, right? So we could develop a tendinitis or a tendon tear with an overwork of the muscle. Or we could just develop muscle soreness, delayed onset muscle soreness, which usually you see with more of an eccentric muscle contraction. We'll talk about that in 1 second. You could also substitute, so if somebody substitutes, you have too much resistance and they're using other muscles to do the action. Okay, you could also see substitution when somebody doesn't have enough strength to perform the action. I said this last week, if I was going to perform shoulder flexion and I had limited shoulder flexion and I couldn't get all the way up, I could be on that stupid ladder that you put people on and you go like this, right? So that looks like more shoulder flexion. When really I'm doing trunk flexion, or I'm doing my scapulothoracic joint as opposed to my glenohumeral joint. Yes, Brian.
In a case like that, like you just showed, so like most patients that move their shoulders, but they're moving like everything. Right? Is there a way to stabilize?
Is there a way for that person not to do this?
Yes.
Yeah, like you find a way for technique to stabilize like what you don't want to.
How do you do that? Proprioceptively, right? So either you give them proprioceptive cueing, you can take them, you can put your hand there, you could hold them, well, it's proprioception, or you can give them visual, because they're going to go home, they're not going to have you putting their hand there, so you say, when you lift, I don't want you to do this, and you show them in a mirror how to do that, or you may tape them down. do a lot of taping too.
Yeah.
Will, will you be doing taping?
Oh, and that was biofeedback, that was the thing about biofeedback before. If somebody comes in, biofeedback, we'll talk about this next semester, but biofeedback can either help you generate tension in the muscle and get a muscle contraction, but could also have you relax the muscle. So I could place pads on a patient and say, you hear the beep? You hear the beep of this muscle because it's requiring microamps. And you're hearing beep, 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 beep because the muscle's contraction, and you say, and it's not complicated, but it's something you have to find out. What is this person's threshold? What's their normal tone? When I take that well side and see that machine isn't beeping, place it on the other side and say, okay, you hear that beeping? That's because you have activity in your upper traps. Now make that beeping go away. Isn't that wonderful? Because they hear beep, 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 beep. You're giving them something, some kind of some feedback for them to say, all right, you want me to shut that noise off? All right, I got to bring my shoulder down. And when they bring their shoulder down, they get the feeling of what that feels like to bring their shoulder down. This may take a half-hour session. When they walk out of there, it's a whole lot different because they go like this and say, oh, now my shoulder's not supposed to be up there, it's supposed to be down here. Then you start to work on all those muscles back here to pull the scapula down and to work on the depression of the shoulder and lower trap muscles more than upper trap. Yeah,
So that's more like conditioning, right?
it's more like conditioning, sure. But this is habit,
Yeah.
right? And this is a motor pattern that's developed over time that you need to change. Can you change it overnight? Absolutely not. Absolutely not. I say to a patient, it didn't take 1 day for you to look like this. It's not going to take 1 day for you to look like this, right? How many years did it take you to look like this? Now we need to get you back here. Hopefully it's not going to take you years because working together, maybe a few months, you'll be where you need to be.
Yeah, so what do you say when a patient goes back and is like, all right, so it's gonna take a long time, like years, or I may never come back to that position?
Well, you got to be realistic, right? So we're going to get you as far as we can get you. We're going to normalize you. We're going to get you out of pain. We may not get you to full upright position, especially if they have a disease, something like ankylosing spondylitis or something. We want to prevent the forward movement. So we're going to say we're going to try to maintain or maintenance. And in that patient, you may see them once a week. You may see them once a month. You may give them a home exercise program and ask them to journal and ask them to tape and ask them to send you stuff. Rather than because you don't want to use their insurance up. You don't want to see them 3 times a week because it's not going to be worth it. Yeah.
For the overwork, does it say this causes temporary, it's going to be temporary tooth deterioration?
All I heard was temporary.
Temporary tooth, permanent deterioration from overworking?
He wants to know what that says. Overwork causes.
Oh, temporary, that should say or permanent, or permanent.
Okay, got it. Thank you.
Sorry. Okay, so substitution. All right. Common difference. Muscle soreness. Muscle soreness will develop anytime you overwork a muscle, yes.
Substitution kind of like similar, like compensated.
Yeah, compensatory. Mhm.
Something like that.
Yeah, so you'll substitute with something. You go to a gym, Chris?
Yeah,
Do you do bicep curls?
not really.
No.
That hurts my AC joints. I
Oh,
already
okay,
had a while.
okay. But you see guys,
Yeah,
right?
I used to do 'em.
You see biceps and they take, but one guy has to outdo the other, so they put like 300 pounds over here. And then they do. Big old biceps. And you just say, gee whiz.
Cardinal sin.
It was, I think I told you the story. I was fortunate to be able to do some work with, she's dead, Florence Kendall. Florence Kendall was like the mother of muscles. She and her husband, they just wrote books on muscles. And she took a guy from the audience, and at the time she was probably 80, 85 maybe. And she took a guy from the audience and she said, which one of you thinks you have good abdominal muscles? And the guy, of course, said, I do. And he came down and she said, take your shirt off. She said, oh, yeah, quite impressive, because he was quite impressive. And she put him on the table and he put his legs up and she said, okay, hold here. And she took one finger and pushed him down. And the guy got really upset because he said, no, my lower abdominals are great. You know, she, of course, positioned him in the way that just to use the lower abdominals, and he couldn't do it. So it's not about what you look like. It's about working the appropriate muscles. I mean, you want to look good, okay, that's a good thing, but you also want to make sure that all of the muscles, because it's like the electricity, following the path of least resistance. If a muscle's weak, it's not going to want to work, something else is going to want to work harder. So that other muscle will become hypertrophied while that other muscle becomes weaker and weaker. So you have to know what your muscles are and how to work them specifically if we want to just work one muscle group. Okay? So muscle soreness, we said, comes after strenuous exercise or if you have a point of fatigue. It usually occurs, they thought that it was a buildup of lactic acid, but it's also it's more so a lack of oxygen. It's usually transient, means that it goes away. Okay? DOMS, delayed onset muscle soreness, will develop within 48 hours, 24 to 48 hours, and that diminishes over a week. That usually happens with the negatives. I'm using your term, not mine.
He said,
The negative, oh, he should have said yes, I know. Eccentric exercise. It usually happens with eccentric exercises, more so than concentric. Because eccentric exercise is one that is with gravity and does not require the same amount of motor units. In fact, it doesn't use the same amount of motor units. There's less motor units available to perform eccentric exercise than a concentric exercise. Yes?
I was gonna ask, how does the delayed onset of soreness, because the muscles aren't firing and they're being put in the lengthened position, does it cause more of a breakdown of the tissue?
Because you get bleeding, you get micro-tearing. You get micro-tearing of the muscle itself. You get bleed, you get lack of oxygen, you get an accumulation of lactic acid. But you actually get tearing of the fibers. And then you have to get cross-binding again to occur. And that usually takes about a week to do because you've got an inflammatory process. If you don't believe me, then ask Professor D'Onofrio, who once ran a marathon. He ran a marathon and his legs were so edematous. He's got huge legs. You ever see his legs? He's got like these huge quads. And he ran a marathon, and after the marathon, and I usually tell this story down in second semester because he went to a therapist. I knew him, and he went to a therapist before he came in to see me because he was selling Dynasplints, so he came in to see me to talk about Dynasplints, and I said, then what did you do now? And he said, I just ran a marathon. I went to a therapist, and they put heat on. There's an inflammatory process. There's bleeding in the muscle, in the fibers. They're bleeding. Do you put heat on blood?
No.
It increases blood flow. Hyperemia increases the inflammatory process. It's contraindicated. I said, a therapist did that to you? And it was true. True story. But this is not something you want to do. You want to rest those legs. If anything, you want to ice them. But you want to rest before you do any kind of exercise again, because you're just going to increase the instability of the muscle. Okay? And we talked about contractures. We talked about joint contractures. There's connective tissue fibrosis. So you could have arthrofibrosis, where the joint starts to become restricted because of the connective tissue around the joint. And you could also have adaptive soft tissue shortening. So an example of an adaptive tissue shortening is if I had somebody in a long arm cast, and they don't usually cast you in complete extension, they cast you in a bit of flexion to make it more functional, a little extension of your wrist. What do you think happens when you take that cast off after 8 weeks? It's tight. You get a connective tissue shortening or adaptive tissue shortening, so you have to manually go in and work with that muscle before you also may need to mobilize the joint. Okay, so we have the connective tissue around the joint. All right, kinetic chains. Open kinematic chain. The distal segment remains free to move in space. That's a definition of an open kinematic chain. Where a closed kinematic chain is when the distal segment is fixed. So what is walking? What is walking? Closed? Open?
Open.
Open? Closed?
I'm gonna go with open.
It's both.
It's closed on the plant leg and open
It's
on
both.
the.
It's closed and open,
Yeah.
right? It's closed on my right, it's open on my left. It's closed on my left, it's open on my right, right? Closed kinematic chain. Yes.
So, I'm curious about this because coming from a training background, does that mean when you do things like plyometric exercise or
Plyometric exercise just loads and puts the muscle on the optimum length tension relationship in order to perform an activity, right?
yeah, so but for in terms of like, not just from PT, but understanding like say the injuries aspect, it's because of the open kinetic chain portion of the exercise where you're going through the motion where people often land and they get injured. Is there like a reason why, like due to instability that these things occur? Or is there like, I don't know how to better word it. It's like, because it goes from a closed to open so aggressively, is that why?
Shouldn't. You shouldn't. You mean, you're saying if a person performs a plyometric activity, they sometimes have injuries?
Yeah, I've seen a lot of athletes, high schoolers that end up
Oh,
getting
high
injuries.
schoolers, there you go.
Yeah,
With coaches that don't know what they're doing.
yeah,
Okay, so you answered my question. Because you shouldn't.
yeah.
You shouldn't. Not if you do it correctly. But we could talk about that. So if I'm doing a knee extension exercise, it's open, right? If I could do this same exercise in closed chain, right? By doing a squat or by coming up from a squat?
Coming up.
Yeah, you gotta go, you stand up,
Hmm?
getting up.
Well, you do
So
both.
is this the same thing as me doing, now you're gonna test me, because this leg is still bad. This leg is doing this or doing this?
Do that.
Which is a closed exercise for that,
You wanna
for
take
this?
the extension.
They're both
Stand.
closed,
One
right?
would be.
Wait, for the squat? Because your feet are both still on the ground for the eccentric and eccentric.
So standing or sitting down?
Stand.
Standing. Standing, because I'm shortening the muscle. I'm not elongating the muscle. All right, this is shortening the muscle.
Right.
Yes.
So I was wondering, like, if you were trying to train somebody through, like, working through, like, block hold or something, like, would you recommend them starting off with open chain exercises and then progressing them to closed chain exercises?
You know, there's a reason to do both. If you want to work specifically on a muscle, on one particular muscle, an open chain exercise is great. A closed chain exercise is better if you want to restore function. You know, because our ADLs are all closed chain for the most part, right? So if I want to work on somebody's function, I'm going to do more closed chain exercises. Or when I did my dissertation on the knee, I looked at a lot, meta-analysis and different things like that, and I looked at swimming and water activity as opposed to something that's more functional. There's no carryover. There's no carryover at all. You can get somebody in a pool and do all these strengthening exercises and all, it does not carry over to function. So you do functional tests on these people and you find that they're no better off than they were to begin with. Because that's all you've done are open chain exercise.
Swimming is open chain, just make sure, right?
What do you use open chain for?
No, like, swimming is specifically open chain.
Swimming is open chain.
Despite the resistance from the water.
Yeah, it's open chain. Okay, so open and closed, we have a fixed distal segment or we have one that's free to move in space? All right. So what are the type of contractions we have? Isometrics, muscle shortens, no appreciable length, change in length, right? No appreciable change in length. So if I went to push against the wall's not moving, This is an isometric contraction, right? It's not gonna go anywhere, it's an isometric contraction. If I went, you guys all know what quad sets are? Everybody? Alan, you know what a quad set is? Okay, if I have somebody, can you get up here? So usually I'll give, can you lie down? So usually what I'll say is I'll put my hand under somebody's knee. Can you see me, guys? Hold on. I won't go on that side, it's a pain in the neck to walk. Okay, I'll put my hand under somebody's knee and I say, push your knee into my hand. Push your knee into my hand. Push this into my hand. Come on, get it down. There you go. Push my knee into my hand. Or I'll put a pillow or something under them and I'll say, push your knee and tighten up your muscle. That's an isometric quad set exercise. Perfect. Is it functional?
No.
How do I make it functional?
Turn into a closed chain.
Terminal knee extensions.
Ah. How do I make that quad set, that isometric contraction, functional?
Stand on the ground and against the wall and push the pillow into the wall as you stand.
Sure. I can place my little ball, tiny little ball, tennis ball or something behind me and do a quad set. Now it's a functional isometric contraction as opposed to, yes.
Isn't that terminal knee extension?
Terminal knee extension is not an isometric contraction. We're talking about isometric, right? No appreciate change in that. Does the foot move? During terminal knee extension, better.
Does, yeah.
Otherwise, you guys are doing the wrong terminal knee extension. Yes, so that's an isometric contraction. Isotonic contraction, yeah.
I guess I'm not understanding that, what do you mean by functional? Because here you're laying down.
Okay, how often do I need to lie down and contract my muscles?
Probably rarely.
Every time I take a step, do I need to extend my knee?
Yes.
Okay. So I need to straighten it at that little joint, right? Otherwise I'll be walking like this. Well, you can't see me, but otherwise I'll be walking with a little bend. This is not very functional, right? As I strike my heel, my knee goes into extension. It's an isometric contraction initially. So that's functional.
You kind of need to do it while you're weight bearing is what you're
Yes.
getting at, okay.
Yeah. Okay? So isotonic exercise, carry out against a constant motion. So the motion is constant. And it's through the available range of motion. However, the speed can change. Okay? But the load is constant. Okay? Give you an example of a isotonic contraction. This is, let's say it was 5 pounds. Did I change the load at all?
Nope.
Did I change the speed?
Yeah.
Am I still going through the full range of motion?
Yeah.
Okay? So that's the definition of an isotonic contraction. We can subdivide these isotonics into eccentric as opposed to concentric. Concentric, the muscle was shortened, so we get a decrease in the joint angle, and we move against gravity, right? Eccentric, we move with gravity, we get the muscle we elongate, so we get an increase in the joint angle, and eccentric contractions require less motor units to perform. So less motor units are recruited, okay? That's why you get more injuries with eccentric contractions, because there's less motor units to perform the activity. Okay? So if I did a squat, a wall squat, and I have quads, and what do quads do? Extend the knee. So I'm doing this, and I'm doing this. I'm doing a concentric contraction of the quads, but which one is eccentric? I'm sorry, I'm doing an isotonic contraction, but which one is eccentric and which one is concentric?
Eccentric's going down, concentric's coming up.
Eccentric is going down, concentric is coming up. Yeah. Can you tell me a biceps eccentric and concentric contraction?
Eccentric into extension, flexion concentric.
And can you tell me a biceps eccentric contraction closed chain?
Closed chain, hanging on a pull-up bar,
Yes.
so.
Hanging on a pull-up bar. So as I control, and I don't drop, letting myself down so that my shoulder's yanked out of socket, it's an eccentric contraction, and as I go to lift up, it's a concentric contraction. Yes?
So like a tricep extension, another one where you go like this and you go down. So that you're using gravity, you're not going against gravity, but the muscle is still shortening. Is that still
No.
concentric?
No, when you just, if you're not controlling the lower and you're just letting it drop,
No, I mean if like, let's, you know the weight stack and then you go like this and you push down.
Okay.
That's concentric.
But you're going with gravity.
but
Or
that's,
no, you're talking about the stack.
but that's a concentric triceps.
Well,
That's not a that's not a biceps.
oh no, I was asking a second.
Yeah.
The weights are going against gravity. The weight, the load.
Just like when I do this, I'm just elongating the triceps, I'm not contracting it at all. It's a passive movement.
Okay. Yeah, no, I guess it's like, kind of like what Steve is saying, it's like, the lever system doesn't matter, it's more about the load itself, that's what.
Yes.
Okay.
Yeah. Okay, so everybody get this, eccentric as opposed to concentric, isotonic, the speed is variable?
Did we do isokinetic?
Not yet. The speed is variable and the load is fixed. Okay? I'm sorry. Isokinetic, the speed is constant, but the resistance is variable. Okay? Why is that good? The speed is constant, and you set these on machines. There's machines, you can't do this yourself. So you set these on some of these Lido or these Biodex or something like that, or some of these bikes. The speed is constant, but the resistance is variable. So why is that good?
It's good because you could overload in the eccentric, causing your muscle to work more, and you can be stronger in the concentric because it's lighter weight. So you're getting like the best of both worlds, concentric and eccentric.
The machine will recognize that you don't have the strength to go through the full range of motion, and it will decrease the amount of resistance it provides. That's exactly what happens. Okay, with an isokinetic exercise. All right, if I used a 100-pound weight and I kept doing this, or even if, this is light, but if I use 20 pounds or something, I'm gonna get tired over time, right? So something's gonna happen. Either I'm gonna change the way I do this, I'm gonna use my back, I'm gonna use something, or if I was really, really a compliant patient and you told me to do this, I would get hurt. So if I had an isokinetic device that I was on, the resistance would be less as I went through the repetitions. The speed is still fixed because you set that in the machine. It's just a resistance that's variable. Okay? Yes?
Does it promote like some more of your doing isokinetic movements?
What about an isokinetic?
Does it promote endurance?
Does it promote endurance? Sure. 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 Okay? So, and a resting muscle is when a muscle doesn't have anything acting on it. So it's just resting. It's at rest. It has a specific length. It hasn't shortened, it hasn't lengthened. So this is something that you should commit to memory, okay? You really should. Because isometric, speed is fixed, resistance is fixed, there's no movement, no visible movement, no appreciable movement. So we said we could do a quad set. What's a ham set? You could do one right now. Slightly bend your knee, don't bend it all the way, but slightly bend it, so keep it near full extension. Slightly bend your knee and dig your heel down into the ground. You are doing an isometric ham set, isometric hamstring set. Now, which I say to little old ladies all the time when I get them to walk and I want them to activate their glutes, I say, pretend we have a penny in between your butt and you have to hold it there. Don't lose it, don't lose it. Squeeze your butt cheeks together. That's a glute set. So these are all isometric. Glute set, ham set, any appreciable joint movement? No. No. Is there a contraction? Yes. Is the speed fixed? Yes. Is the resistance fixed? Yes. Isotonic, we said that the speed is variable, the resistance is fixed, this, and there is joint motion. And then we said isokinetic, the resistance is variable, or some people use the word accommodating. You have accommodating resistance. It accommodates to your muscle strength. Yes?
Okay, sorry. This may sound like a dumb example, or it may not even correlate, but would like a game of tug of war count as isokinetic?
As long as both people are strong, as long as both teams have the same strength. Absolutely. Absolutely. Once one team starts to win, or starts to pull you over, then it becomes isotonic. Okay?
And
But that's
if one person falls off, then it's isotonic.
Oh, stop. Okay, so we getting this? We getting this? All right. So, some more common definitions here. Irritability is the capacity of muscle to respond to a stimulus. So that stimulus can be either a motor stimulus, a manual stimulus, or a nerve stimulus, electrical stimulus. It's able to respond to a stimulus. Can be contract. It's the ability to shorten or lengthen. So we already said we have a concentric or an eccentric contraction. It has the ability to stretch or to lengthen once you apply a force to it, like saltwater taffy, right? So you take saltwater taffy, you pull it, it has the ability to stretch. It has the elasticity, it can recoil. So like a slinky has elasticity as well as extensibility, right? It can recoil, but it can come back to its normal set point, as opposed to a ligament that once it's stretched, it's stretched. Okay, once it's torn, it's torn. It doesn't have that capacity to come back. Then there's this length-tension relationship. There's slight tension in a muscle at all times, but we do have a when a muscle is able to, and it shouldn't say half, it's like a third. No, it's half, like 1.5. It's lengthened about 1.5 times. So not. Muscle can be shortened and lengthened half of its normal resting length. It can actually be shortened half its normal resting length and lengthened 1.5 times its normal resting length. Okay, so just put that in there.
Yeah.
1.5 times its normal resting length.
That's the tension force.
All right.
Yeah. Lengthen 1.5, right?
Yes. Now, we have two joint muscles and we have one joint muscle. We have multi-joint muscles. I gave you guys an example of a two-joint muscle. It is one of the quadricep muscles is two joint. The rectus femoris is a two-joint muscle. The rest of the quadricep muscles are one-joint muscles. So if you have a two-joint muscle, it has to cross two joints, right? Does it have the ability to do both things at both joints optimally? No. So, but when you have a two-joint muscle, if you put a slight stretch on the muscle before you use it, you have an optimal length-tension relationship. So think about when you kick a ball. We don't kick a ball this way, right? We usually put our leg like this before we kick it. So we're putting the hip flexors on stretch before we're actually kicking the ball. Length-tension relationship. Has to also do with sarcomeres and actin binding to myosin and cross bridges that are formed. Okay? But just, you don't have to know that. We're not going to go into detail on that. What I do want you to know that the optimal length-tension relationship for a muscle is to put it on slight stretch. Okay? So, and your book gives you an example of that the tension becomes stored in that muscle and makes it stronger. So think about when you shoot in an elastic band or a rubber band. We stretch it prior to releasing it, right? So we have energy that builds up within that, or tension that builds up within that band to propel it further.
That's the stretch shortening cycle, correct?
Excuse me?
That's a stretch shortening cycle?
Yes, similar to a stretch shortening cycle, yes. Okay, it also has to do with, when we talk about force, it increases the force, the generability of the force in the muscle because force equals mass times acceleration. Well, and work equals force times distance. So the greater work would then be energy. So we have a lot more energy that's accumulated, so to speak, if I went to clap like this, then clap like this. So I'm increasing the distance. That's basically what's happening. And if I increase the distance or the length of the muscle, I'm increasing the force, or the amount of energy that's accumulated within the muscle itself. Okay. So, length tension relationship, this is the excursion or the functional excursion of a muscle. This is a normal resting length of a muscle is 6 inches, right? So I said it's capable of shortening half its length, so it can shorten to 3 inches, and it's capable of lengthening 1.5 times its resting length. So let's do the math. If the muscle is 6 inches, and it's capable of lengthening 1.5 times its resting length, what does that equal? 9. So what's the excursion of this muscle from its maximal shortening to lengthening? 6 inches. Okay? That's easy math, right? Adding, multiplying, you lose me? Okay, you got me, Ashka? Okay, Ashka's going to put it in her notes. All right. All right. So the excursion of a muscle is distance from maximal elongation to maximal shortening. And that picture that we had was 6 inches, 9 minus 3. All right. We'll talk about muscles a little bit. When a muscle contracts, it doesn't know its direction, right? It's not, usually when a muscle contracts, we go from its insertion to its origin. Okay, so usually moves from insertion to origin. Not always. Sometimes we have reversal of action of a muscle where the origin moves toward the insertion, especially when one part of it is fixed. We'll talk about that a little bit more when we talk about muscles specifically. But generally, if I say that my biceps muscle, and I use this a lot because I've already said it to you guys, is originating on the supraglenoid tubercle as well as the coracoid process of the scapula, inserting into the radial tuberosity or the sort of fibrosis of the radius, as it's contracting, the insertion is being pulled toward the origin. If I did an eccentric contraction, then the opposite would occur, yes? So now I would be moving away. The insertion is moving away from the origin, right? Just know that for now. We'll talk about other things later, but just know that for now, okay? So can you see that? So here I am using this thing and bending my elbow. And now this is really heavy, and I have to control it going down. So if I said the insertion was at the radial tuberosity, I'm bringing that closer to my shoulder, right? Where I said it originates. But now I'm controlling it, and I'm bringing it down, and I'm bringing the insertion away. Yes? Basically, when a muscle, that's why I say when a muscle contracts, it doesn't know any direction. It just contracts. Everybody get that? So reversal of action, the origin moves toward the insertion. That's what I mean by that. Okay? And we're going to talk about that a little bit too when we talk about Trendelenburg. And we'll talk about it a little bit more functioning, but we have to learn those muscles first.
What would be an example of reversal muscle action.
Just now, what we said,
Eccentric.
yeah. Reversal of muscle action. Okay? All right, so here's the lever, here's the fixed lever, here's flexing and then extending. Let's see, muscle names. So the name of a muscle often tells you a lot about the muscle. It does. It tells you a lot about the muscle. Tells you where it's located, tells you what shape it might be, the action of a muscle. So if it's a flexor carpi radialis, what do you think it is?
It's radius.
It's a
Thumb
flexor
Thumb side.
carpi
Forearm.
radialis. What does carpi mean? What carpi refers to wrist, right? So
Flexor.
it's a flexor carpi. It flexes the wrist. Radialis.
Thumb side.
It also radially deviates the wrist. Yes. Yes. So there's a lot of muscles that tell you what they do. So it's not like you're going to have a hard time remembering what they do. Maybe where they are, because the flexor carpi radialis is actually coming from the common flexor tendon, which we'll talk about, and it's inserting to the second and third metacarpal of the hand. So it's crossing the wrist. So it's coming, it has an action at the elbow and the wrist because it's a two-joint muscle. Okay. It also has a specific number of heads. So when we say biceps, we think bi, we think two. So we think two heads. When we say triceps, we think three. We have three heads. Okay? The direction of the fibers, if you can visualize what this muscle looks like, you can figure out what it does. Remember I said to you day one, I said we have a pectoralis minor that's originating from the second through the fifth rib. Second through the fifth rib. And it's inserting into the coracoid process. How do you find that coracoid process? We go where the angle changes, we put our hand back like this, we feel a bump, that's a coracoid process, right? So, as this muscle pulls, because usually insertion toward origin, right? It's originating here, it's inserting here. As it pulls, what's it doing to the scapula? It's pulling it up, and it's causing that inferior angle to pop out, right? It pulls the coracoid process down. Just by knowing what this muscle looks like. Just by knowing what it looks like. So that's why we're going to do, I have cadaver tape. It used to be free on the internet, it's not anymore. I guess they got wise. But I do have it, and I will lend it to someone who's reliable if they want to copy it and copy it for other people. But it's a wonderful tape. Or not tape. I have it on a thumb. Yeah. USB. Okay. All right. I think we'll stop here. So we'll continue on Thursday. I will send you guys an email as soon as I get off the phone this afternoon and let you know if Thursday will work out. And so we'll do a written test next week. How's that?
Thursday?
You think Tuesday?
Thursday.
I think Thursday's best.
I got whatever you got. Whatever you got for me, I'm ready.
I'm standing in the Thursday train.
All right, we'll talk about it.
I'll be a